Hello, everybody. Welcome to our SIO monthly webinar, and thank you for participating with us today. As a reminder, the webinar will be recorded and posted on the SIO YouTube channel for your reference. If you have any questions during the presentation for Dr. Bossis, please send them through the Q&A box at any time located in your toolbar. Dr. Bossis will then answer the questions at the end of the presentation, and you can also use the chat box to ask any questions to the organizer directly. So joining us today, we have Dr. Anthony Bossis, a clinical psychologist and clinical assistant professor of psychiatry at the NYU School of Medicine, and an adjunct professor of religious studies at the University of Ottawa, and an investigator of the Lundquist Institute for Biomedical Innovation, conducting FDA-approved clinical research with the psychedelic compound psilocybin. Dr. Bossis was a director of palliative care research and co-principal investigator on the 2016 clinical trial and publication of Journal of Psychopharmacology, demonstrating a significant reduction in emotional distress from a single psilocybin session in persons with cancer or at the end of life. Dr. Bossis is also the study director on an FDA-approved clinical trial evaluating psilocybin-generated mystical experiences upon religious leaders. He is a training supervisor of psychotherapy at NYU Bellevue Hospital Center and the co-founder of the Bellevue Hospital Palliative Care Service. Dr. Bossis is on the editorial board of the Journal of Humanistic Psychology and a guest editor with Charles Grob, MD, for the journal's special series on psychedelics. He maintains a private psychotherapy and consulting practice in New York City. Dr. Bossis, thank you for joining us today, and please take it away.
Thank you, Morgan. Thank you very much. Hi, everyone. Hope everyone is doing well today. And I want to thank Dr. Eugene Ahn for this wonderful invitation. It's great to speak to this group about this topic. So I'll speak for about 45 minutes, then we'll have some Q&A and a conversation, which I look forward to. And the topic today, as everyone knows, is the reemergence of psychedelic research in America. And it's been an exciting time for this research, and we're still in clinical trials, but we do hope in 3 to 5 years that psilocybin may be rescheduled, allowing it to be used clinically for specific indications, and certainly the end of life and cancer distress population and palliative care would be one of those. But a quick mention of the historic note of all this: there was a very large wave of clinical research in the 1960s and 50s and going into the 1970s with psychedelics, primarily with 2 indications. One was for alcoholism, and the other was for terminal cancer patients. So our teams proudly stand upon the shoulders of these giants back then who did this research prior to it being shut down because of the cultural phenomenon that went on back in the 1960s. But the clinical use was very robust, and we'll talk about that. And we're happy to be picking up the ball in the last 15 years. So with that, I will move forward. So this audience, I know, knows a lot about the emotional suffering that can accompany a cancer or end of life or life-threatening diagnosis, but I will somewhat briefly review some of these markers in palliative care and in cancer. I will walk through a bit about the importance of meaning and transcendence, which are really 2 hallmark features of this experience that psychedelics can generate in this one-time 3 to 4 hour altered state of consciousness that we will talk about today. The features and the experiences of meaning and transcendence are really key, and we'll talk about that in more detail. I will walk through a brief history of psilocybin and psychedelics. It's a pretty long history and a rich history, and it's quite colorful, going back thousands of years in terms of these medicines being used by indigenous cultures and also in antiquity for religious purposes, for insight. And of course, over the past half a century or more, we've seen it used in medicine to relieve suffering and a variety of clinical disorders. And today we're seeing quite an emergence of many clinical disorders being treated by psychedelics. We'll discuss something that's important to this research that we're going to talk about today, and it's the mystical or peak experience. It's a specific state of consciousness that these medicines can generate in this one-time episode. But in our work at NYU and the work at Hopkins with cancer patients, it's been shown to be correlated with greater outcomes, better outcomes in terms of reduction of suffering. So we'll talk about what that is. And I'll present the research briefly from the first wave, going back more than a half a century, the current research, and I'll present in detail our findings from the NYU cancer study. And I'll talk a bit about the Johns Hopkins trial as well. We published our papers together in 2016. And there's a number of trials now getting started again with this population. And I can speak later about a new study we're going to launch, hopefully the end of this year, early next year, a multi-site trial with psilocybin for people in palliative care. And we'll discuss implications for the future. So a few slides on just the background. As many people in this audience know, we don't die well in America. I am hopeful, and I'm heartened that we are getting better at the cultural conversation. As Ernest Becker's book, The Denial of Death, implies, we really aren't great about talking about end of life in our culture, but the past 15 or 20 years has seen quite an improvement with best-selling books and things like end of life doulas and death over dinner conversations, and of course all the work that palliative care and hospice movements and psycho-oncology have done in advancing the conversation, both in healthcare and medical schools, and of course in the culture. And as this slide shows, and it's an old Gallup study, but it still kind of, unfortunately, has merit. Many people still die in ICUs, and where they'd rather die at home with family. So we're getting better at how we do address the end of life. And this also, I recently wrote these dates down beneath it to remind myself how long it's been. And again, we're improving, but we're still, it's an avoided conversation in the culture. End of life and terminal disease or life-threatening disease is an avoided conversation, also in healthcare circles. In 1997, the Institute of Medicine really called out for a change. There was a mandate to have healthcare really improve how we treat people with advanced disease or at the end of life. And sadly, all these years later, although things are improving, one study showed depression on the final year of life had increased by 26%. And we know that through an abundance of literature that depression and hopelessness are strong predictors for a desire for a hastened death in end-of-life patients. And something I'm going to talk about a bit today is a demoralization syndrome that I'm sure all of you are familiar with, and it's emerging as a really important patient experience or construct in psycho-oncology and palliative care. And it's a state of hopelessness and meaninglessness and despair. It's a burden on these patients. And the important thing about this is that with this emerging literature is showing that demoralization and depression don't fully overlap. So while some patients who endorse major depressive disorder or depressive features may have demoralization, many people with demoralization don't have depression. We don't see the full overlap. So it seems to be a distinct and separate experience or concept. And the problem with that is that sometimes people who endorse major depression are being treated, but people with demoralization are not being identified. Now, the other important thing is that while medication may work with people with major depression, it seems to work less with people with demoralization. What works better is a meaning-making approach, like the meaning-making psychotherapies. And as I'll walk through today, one of the remarkable parts of the psychedelic work is that it does generate these meaning-making experiences. And as many people here today know, palliative care affirms life in regards to dying as normal processes. It neither hastens nor postpones death. It integrates psychological and spiritual aspects of patient care. And of course, it encourages life review with recognizing purpose and value and meaning. And then those last two items are really important to how we do the work with psilocybin. Psychological and spiritual functioning and a focus on purpose and value are at the heart of these sessions and of the psychedelic therapy. And I won't go through all this, but I think everyone here knows the abundance of literature on uh, um, end of life distress, cancer, anxiety, some high numbers in a variety of publications over the years with people with cancer or with end of life disease. And depression and hopelessness were again strong predictors for desire for a hastened death. Depressed patients who were 4 times more likely to have a high desire for a hastened death compared to non-depressed patients. And really importantly is that among neither depressed nor hopeless patients, none had this high desire for a hastened death. And that's an important feature and important insight as we move forward with this research, because this research so far in a few studies, clinical trials, has shown to reduce demoralization, which I'll show you in a little bit, the data, and reduce suicidal ideation in a small data set, and hopelessness as well. And then again on demoralization. So just an example of what I'm referring to. In one study, we see demoralization in cancer patients may be more strongly linked with suicidal ideation than major depression. There's been many studies, but in one review of 6 studies using a demoralization scale that we use, and we're going to use in our new trial, rates in the range up to 22% in palliative care end-of-life patients had demoralization, but didn't meet the clinical depression criteria. So again, patients might be not being identified in a very important cohort. This is an important study many years ago, not about psychedelics, but about it was a meta-analysis on the important themes that patients report at the end of life. And the 2 most important features were meaning and transcendence. And again, for me, that seems to form the heart of the psilocybin-generated experiences that we're going to talk about today. And the great Viktor Frankl, who I'm sure many of you know, who is a Holocaust survivor, and himself developed a meaning-making psychotherapy called logotherapy, which does address demoralization. He said meaning can be found in life literally up to the last moment, up to the last breath, even in the face of death. And then now, and also in psycho-oncology literature and palliative care, we're seeing an abundance of articles calling out for more that meaning and spirituality are really effective in how we cope in life in general, but also with navigating a serious illness. And there's been a call for emerging novel therapies to address this often untreated population. And I believe, and I think the audience would agree, that psychedelic therapy is a novel therapy. And Viktor Frankl, again, man is not destroyed by suffering. He's destroyed by suffering without meaning. Forgive all the words on the slide, but I want to read through an important few sentences. There was a wonderful article written by Eric Cassell back in 1982, many years ago already. It was not about psychedelics, but it was about what he felt was missing in how we treat patients. And it became a very popular article in the New England Journal, and I recommend people read it who haven't. And then evolved into a book. He wrote about this transcendent experience that's integral to our life. He wrote, in part, transcendence is probably the most powerful way in which one is restored to wholeness. Everyone has a transcendent dimension, a life of the spirit. This is most directly expressed in religion and the mystic traditions. When experienced, transcendence locates the person in a far larger landscape. Such an experience need not involve religion in a formal sense. However, in its transpersonal dimension, it is deeply spiritual. The quality of being greater and more lasting than an individual life gives this aspect of the person its timeless dimension. And you're going to hear later in vignettes that I read from patients who've had these experiences that timelessness experience, that transcendent experience was key in recalibrating their personal sense of despair. The profession of medicine appears to ignore the human spirit. When I see patients in nursing homes who have become only bodies, I wonder whether there's not their transcendent dimension that they have lost. And Cicely Saunders, who co-founded Hospice, wrote, "You can find a degree of wholeness as a person whether you get better or not, whether you are suffering or not. And I've seen people find wholeness as they die. And certainly we see in palliative care and in psycho-oncology, people can find wholeness and relief and dignity even at the end of life. And Elizabeth Kubler-Ross, if you're whole again, you're healed. So, and just a sample of so many regulatory bodies calling out for more effective therapies in treating the end of life distress, which really, while there are developments, including many psychotherapies like dignity therapy and logotherapy and meaning and purpose and meaning-centered therapy, we still have a paucity of approaches to really treat this existential angst that can accompany people after a terminal diagnosis. So today, the medicine we're talking about, the medication we're talking about is psilocybin. We're still in clinical trials. And psilocybin, with street lingo, that it's been called the magic mushrooms, but psilocybin is the active compound, the psychoactive compound found in many species of mushrooms. We really have evidence that it's been around for millennia, if not thousands of years, and used by indigenous cultures and the Aztecs and others for the purpose of spiritual insight, for the purpose of meaning, and not for recreational use. I won't dive into the neuroscience today, but it does involve the serotonergic pathways of serotonin and primarily the 5-HT2A and 5-HT2C receptors. Interesting enough, psychedelics do not lead to addiction or dependence. It doesn't really trigger that same reward system that other drugs can trigger. In multiple surveys now, there's been a link between a lifetime use of psychedelics or a use of it and a reduction in suicidal thinking or mental disorder. So it's quite interesting. And again, we're in the infancy of this new reemergence, so we look forward to many years now of good clinical trials and research. And people have seen it out in the press and in the media the past couple of years. And we're discussing here, though, not the recreational use, but a use really in a very specific way, in a very therapeutic way, in a therapeutic paradigm that was really developed back in the early 1960s. An example of its historic use in the Mayan culture, we know from 1000 BC, they used the psilocybin mushrooms for spiritual purposes. And here we see on the top of the screen these mushroom stones, and we see pottery with various mushroom drawings. There's strong scholarly evidence that in ancient Greece and classical antiquity, for 2,000 years at the Eleusinian mysteries in Greece, there was a psychedelic substance use, probably linked to an ergot alkaloid, similar to psilocybin or LSD. People like Plato and others participated. So there's evidence of psychedelics being used historically in Western and Eastern cultures, which is really interesting. That's the site in Greece. I was there about, I guess, 15, 20 years ago, and that's the chief archaeologist. It's about 8 miles from Athens, and this is still standing, and the site is still there, where people came there once a year for an experience, and hopefully, it sounds like provided insight to them. We also see it in the Rig Veda and some of the more Eastern cultures. And then fast forwarding 2,000 years, in the 1950s, a banker and an amateur mycologist, he studied mushrooms, Gordon Wasson and his wife, who was a physician, had heard about these hallucinogenic mushrooms. Now, until this point, there's no evidence in Western culture of these mushrooms existing. And he went to Mexico in search of these, and he came across this woman you see in the picture, Maria Sabina, who was a healer, a shaman-like woman, and he participated in a ceremony using psilocybin, and a very profound emotional and spiritual experience over the hours that the drug was taking effect. He wrote about it in this Life magazine in 1957, and quickly psilocybin began to be used as a medicine or in research. Before that, LSD was being used in clinical trial in research, but this introduced psilocybin to the scene, and soon it was synthesized and used in research, particularly with alcoholism, understanding consciousness, and also with terminal cancer. So importantly, I want to review just quickly the mystical experience. This is a hallmark feature of the research, and it goes back really to the early 60s, where this was first identified as a tool, and it's been updated and revised, and it certainly has validity and reliability now as a clinical measure, but it's still the same heart of themes. And it's called the Mystical Experience Questionnaire. And these are features that persons under the influence of psilocybin during this, it's a 6-hour experience, 3 hours of this peak altered state that I'm going to talk more about in a moment. When these features are endorsed, when people endorse this mystical state of consciousness, we found a better correlation. It was a predictor of better outcomes with their coping with depression, anxiety, hopelessness, demoralization. About 2/3 of our patients had this experience. Now, the others, although they may not have had this unique experience, psilocybin can still be very therapeutic in other ways. It could generate a very strong autobiographical or psychodynamically life review and address unresolved conflicts through the memory of these experiences. But this mystical state seems to be correlated with the greater outcome. And there's only a few features. And one is unity, a subjective sense that all things are connected. In this altered state of consciousness that people are on during this day-long event, taking psilocybin, that all people and things are interconnected. There's the noeta quality, a term coined by William James, that as if one is encountering ultimate reality. You know, in all the hundreds of cases now that exist in medical schools in the country who do the research, it's rare or never that someone says after the experience, well, that was wonderful, or it was not, it was challenging, but whatever it was a temporary drug effect. The language we hear more is that was ultimate reality, or that was a piece of reality that's real. It's more real than this, or that's a part of who we are that we don't have much contact with typically, but it has meaning and it speaks with authority, and it cultivates insight. Sacredness, people report tremendous experiences of awe, humility, holiness, and wonder. A deeply felt positive mood of joy, peace, and we'll talk about love in a bit. People often speak about this incredible sense of love towards themselves, towards others in their life, and have a greater connection to something maybe larger than whatever the soul is, consciousness, that it's made up of a feeling called love, which is interesting to hear repeatedly in these scientific studies. There were also very difficult stretches that we'll talk about today as well. It could be, an encounter with the self, to paraphrase Jung, can be a very traumatic experience, dramatic experience, particularly with people with cancer. And so that's the reason why we prepare people for this carefully. Therapists are well trained. We're there the entire time, and there's a model we use that I'm going to walk through in a few minutes. It doesn't mitigate a tough stretch during the experience per se, but people don't leave with any serious adverse effects. And during the tough stretches of this altered state, there is typically insight to be learned by moving into the suffering or the distress. Typically, we're finding people can identify and cultivate meaning versus just trying to avoid what's coming up. So we'll talk about that in a bit. Ineffability, people always say it's impossible to describe what I went through, but they write beautiful journals about their experience, and I'll read to you some of their words today as well. And again, transcendence is so important. This subjective feeling of transcending past, present, and future, transcending the body as we know it, our physical being. And for a person who has advanced disease or advanced cancer, and whose body may soon begin to fail and not work, the insight they report to us that I'm not just my body. I'm not just this cancer. There's something more enduring about whatever I am, whatever it is that is the essence of who I am. And that's really remarkable language to hear. And that may continue in some ways. And that's, and also they have insights into the mystery of consciousness and death, and less fearful and more open to that unfolding. And others may not have insights in that way, but have a pronounced sense of gratitude for having lived this one life, and have a more pronounced sense of capacity to be in the moment and enjoy the days they do have versus the ongoing worry and stress that, of course, illness can generate. And Abraham Maslow, the great American psychologist, wrote, to the extent that all mystical or peak experiences are the same in their essence, all religions are the same. And he goes on to say that this common part of who we are is our core transcendent experience. And makes the argument, as do many, that this is a key part of who we are, what it means to be human. And there's a Pew study showing about half of Americans have these experiences, not with psychedelics, but throughout life, people have glimpses of bits of these peak experiences through meditation or being in nature or spontaneously or being in love, and or trauma can cause that. But these medicines seem to reliably generate it in the right setting for a period of hours. And of course, the last century, many books about the experience, not psychedelics, but about this experience. William James, that book is a great book. Richard Buck's Cosmic Consciousness, I fully recommend. Rudolf Otto, Carl Jung. And Albert Einstein, who I believe was a mystic, wrote, the most beautiful and profound emotion we can experience is the sensation of the mystical. So moving into the research, in the early 60s, there was a study with providing psilocybin to healthy young students. It's called the Good Friday experiment. It took place in Marsh Chapel in Boston. And half got a placebo, and the half that got majority, 9 out of the 10 that got psilocybin, reported this profound mystical experience, the kind that we see occurring naturally throughout the ages. And that was really interesting. In 2006, Johns Hopkins replicated that trial, given psilocybin and a placebo to healthy people, and again found that about 2/3 had that experience, and about 2/3 reported one of the most important experiences of their lifetime. So it seems that there's a biological basis for these experiences, that humans are wired for meaning making. What these medicines seem to be, so far in the clinical trials, have the capacity to generate that in a very strong way. And of course, I'll show you with the clinical outcomes. That's the room where that first study took place in the 1960s. We were there for a palliative care psychedelic conference right before COVID hit. This is, I think, early 2020, and we took a trip over to the place where this historic research trial took place. Houston Smith, the great comparative religion scholar, was also a member of that trial. And we give a high dose with the goal to generate that peak experience. A psycholytic therapy is a therapy used many years ago where it's a smaller dose to facilitate a psychotherapeutic process or psychoanalysis. But we give a high dose, we want to generate that mystical peak experience. Aldous Huxley was a big proponent of all this. I'm not going to go there. So for the service of time, on the top half of the screen, you see some of the trials done in the early wave. Many were done at Spring Grove in Maryland, and really this team developed this model we use to this day of each patient is screened carefully. There's weeks of preparation for the experience. There's the session day where they take the medicine in a safe, supportive setting that I'll talk about in a moment, and an integration period where they can address and therapeutically integrate the insights and the experiences or the challenges from the experience. Sadly, it came to a stop in the early 70s after President Nixon had signed the Substance Abuse Act, and because of the large cultural phenomena going on and some political developments as well, these medicines were taken out of the use of the public. They had been legal, but unfortunately, it also stopped the research. The funding dried up, and what was a promising paradigm of research came to a full stop until recently, the past 15, 20 years, where it's re-emerging, and we're really happy to explore these applications. On the bottom half of the screen, we see some of the 3 recent psilocybin trials to date. There are more occurring now. And as I said earlier, we're going to start a new multi-site psilocybin palliative care trial later this year, probably 5 or 6 different sites across the country. And we hope within 5 years that this may be a medicine prescribable that can be prescribed for people with cancer distress. So our NYU trial looked at 1 dose of psilocybin to explore its safety, its efficacy in people with cancer. Many had moderate to advanced cancer at the end of life. Over a third or close to a half have passed away. A few had earlier stage cancer, but the key inclusion criteria was that there was also a fair amount of psychosocial distress that accompanied the cancer. As our team from the early days, and now things have grown greatly. A few quotes from some people in the trial after the trial was over, and I'll read you some vignettes later on as well. Many of these people have since passed away. This changed my life. I can't imagine it regarding to the fear of cancer. I felt a state of becoming. I felt gratitude like I never felt. I felt welcome. And the words you're seeing that we hear all the time, and we hear it at other sites and all the clinical trials and research going on in Europe and in the States, more often than not, you hear this kind of language. There's also difficult stretches, but we hear these insights coming out in terms of the therapeutic benefits. Death doesn't matter, a remarkable thing to hear from a person with cancer. Less afraid of death, that is part of life. This is a person who was in early stage, but had a crippling fear of recurrence. And she's doing well. And she actually had cancer again, and she's doing well again. And we're still in touch with her. And we're really also just so respectful of these participants who took part in these important clinical trials. I experienced the feeling that one is eternal. All of existence happens in a moment. Again, that transcendent, unitive experience we hear about. And everything is love, which we hear often about from our wonderful patients. The red variables were the primary variables in our cancer trial, same with the Johns Hopkins trial. But we also looked at other things, purpose and meaning and forgiveness questionnaires and demoralization scale. So there's a lot of data coming out of this trial still. So there are three main periods. One is the preparation period, where we get to know the person fairly well. We review their life, we review their intention for being in the trial. And an important part of this period is to develop a sense of trust and rapport with the two therapists who they're working with, typically a male and female therapist. And that trust and rapport is crucial. We believe at minimizing adverse effects during the experience, that they're trusted, they're safe in this room with us under this dramatically altered state of consciousness. And we provide guidelines to trust the experience, trust their consciousness, trust us, of course, and that they're safe, and we're medically monitoring them, their blood pressure and their heart rate, and we're there the entire time to assure them they're safe and to provide them with things they may need, walk to the restroom, a drink of water. But typically they stay lying down on the couch, and I'll show you the room in a moment, wearing eye shades and headphones. And the purpose of that is to distract from consensus reality and cultivate a inward focused attention into the unfolding changes in consciousness. There's very little talking during the day. There can be if they want to talk, but typically they stay in the experience with the recommendation to learn, to move into whatever's coming up in consciousness with it seems the understanding that in these altered states of consciousness for that person, insightful things are unfolding. And we hear very dramatic stories, and I'll read to you some quotes later. There's the medication session, then there's this post session integration. Set and setting are crucial. Set means the mindset of the person, their history, how they're prepared, and setting how it's done, where it's done in a safe setting. Psychedelics have tremendous risk of psychological distress and fright, really in terror if not done properly. And that's called, the bad trip in the culture. But in these experiments that we do, there's a real controlled, interpersonally supportive setting where we don't see those experiences after the experience is over. That's the room, first study room that we did it. It's in a hospital, it's at NYU, but it's a comfortable living room-like setting. The patient lies on the couch. We spend 4 weeks here doing the preparation, preparing for it with these recommendations, how to approach it. And then the session takes place here, and then so does the therapeutic integration. This is a busy slide, but just briefly, there's weeks of preparation. Every person serves as their own control. So in this trial, as well as in Hopkins, people who got psilocybin the first time, then 7 weeks later get the placebo, and people who had placebo the first time then get psilocybin. And then for months we're they're completing measures on various clinical measures, and we followed them up to 4.5-year marker, and I'll show you that data in a moment. Most of the people, more than 2/3, had advanced cancer. It's stage 3 or 4. I'm going to go through that because we're running a little late and show you some slides. Some of the data. So the red vertical line here is the day of administration of the psilocybin on the couch in the room that day. The day after, we start administering measures on anxiety, depression, hopelessness, a variety of tools. And you see here the pink bar is the psilocybin group, and the blue is the placebo group. And this is before the crossover. After the crossover, both lines merge because the placebo group then gets psilocybin. But prior to the crossover, we can compare psilocybin versus placebo. You see these effect sizes on top here, pretty large, 1.39, all over 1.0, which as researchers know here, that it's remarkable numbers for psychotherapy for research. Another anxiety scale, again, the day after the trial, the psilocybin group drops to a significant level statistically and is sustained until the crossover. This is the hospital anxiety and the heads measure. Again, we see these large effect sizes on top, and we see the dramatic decrease immediately with psilocybin. The Beck Depression Inventory, same thing. So prior to the administration, there's no statistical change. Then significantly, we see these changes occur the day after the dose. Importantly, we talked about demoralization. Again, hard to treat in our population of persons who are suffering or addressing distress and cancer. And here we saw an immediate drop in the psilocybin group versus the placebo group in demoralization, and also in hopelessness. And that was sustained for the end of the trial, which was 8 or 9 months. And that was sustained at the 3-year and 4-year marker that I'm going to show you in a minute. This is a scale that identifies something even more enduring than oneself or death, and that also received a large support. We saw positive behavioral changes, a lot of data to go through. We saw on top, you see, if you see here, it's kind of small, but for this one, so a personally meaningful experience. In the 2 weeks post that first dose, we see the pink bar, the psilocybin group, have a very large increase in personal meaning. And then after that, both groups have both psilocybin, they're equal. The same with spirituality, the same with well-being. Almost 90% of the people reported an improvement in well-being. About half reported it as being the top 5 most spiritually significant experience of their lifetime. And we hear there's a lot of markers like that. This is the Hopkins trial. It's a busy slide. Essentially, it's the same results. They use not a placebo, but a low dose of psilocybin, very low dose versus a high dose. And that red bar is the placebo, the psilocybin group. But same outcomes. We published it together in 2016 in the Journal of Psychopharmacology. Immediately following the day of administration, the high dose group had dramatic reduction and sustained reductions in depression, anxiety, and other measures versus the low dose group. And 4.5 years later, we contacted the surviving members and administered some scales to fill out. And we see again at the 3.5 and 4.5 year marker, anxiety and depression were sustained. Now, one caveat, one limitation, this is years later. And of course, this is after the crossover. They all had psilocybin and or placebo. So that's an important limitation of sorts, but it does speak to what we believe is the sustainability of these experiences. And same with demoralization. At 4.5 years later, we see this change. Again, I spoke about this increase in meaning making and spirituality. There were no serious adverse effects in our trial, nor in Hopkins. There was some elevation of blood pressure. That's people who have untreated hypertension would not be admitted to a study like this. Some headache and nausea, but those are the only significant medical side effects. Feasibility was established. Up to 80% had significant results at the end of the trial, and now we see at the 4.5 year marker. Again, importantly and remarkably, that mystical experience, those features of unity, transcendence, meaning making, sacredness, were predictors of better outcomes, and that's really important. And we're still looking into these scales. We'll be using that scale in our next big trial that's going to take place hopefully next year. This is Patrick Metes. He was Some of you may know his name from the Michael Pollan book, and a lovely gentleman who I had the honor to work with, the privilege to work with. He passed away about a year after the trial was over. He had an awful diagnosis, cancer of the bile duct, and a very grueling chemotherapy. And he had a very remarkable experience, a very therapeutic experience that he is profiled in Michael Pollan's book. And he wrote beautifully in his journal. We asked patients to write as much as they can about their memory of the experience, the night of and the week of the experience. And he wrote, in part, he wrote a beautiful journal. He was a successful journalist, and he owned restaurants, and a musician, and a lovely guy, really sweet gentleman. And part of what he wrote was, from here on, love was the only consideration. He's referring to his experience, what he went through. Everything that happened, anything and everything that was seen or heard is centered on love. It was and is the only purpose. It was so pure, the bliss indescribable. There's no way to accurately describe my experience. I've had no earthly pleasure that's come close to this feeling. No sensation, nothing in my time on earth has felt as pure and joyful as the height of this journey. And he had a wonderful life, a wonderful marriage. Some people have these incredible experiences of seeing in their body, they say, and or even approaching death and having kind of death rebirth experiences. They're quite remarkable. He had that experience. I won't speak about it here, but it was very powerful, this kind of death rebirth experience that we see in these episodes. But he said he took a tour of his lungs. I saw my cancer. There were nodules there, but they seemed unimportant. I was being informed to not worry about the cancer. It's minor in the scheme of things. The real work to be done is before you, love. Undoubtedly, my life has changed in many ways I may never fully comprehend. But I now have an understanding and awareness that goes beyond my intellect, that my life, that every life, all that is the universe equals one thing, love. Patrick reported that it's the single most spiritual experience of his lifetime and the top 5 most meaningful. I was with him about a week before he passed away. I went to visit him. And this is a picture of him days before his death, and he looks thin from his disease, but he looks remarkably content. Didn't want to die, didn't want to leave his lovely wife in this world we have the precious years to live in, but his fear dramatically reduced. And when the session began, after 2 hours, we're all double blinded, and we're sitting there watching him, and he's lying down, and at the 2 hour marker, he just says one sentence: birth and death is a lot of work. Then he went quiet again, and he later reported that was the start of his incredible experience, and an incredible person and a pioneer for us. Great Thich Nhat Hanh, who died recently, the teacher and Zen monk, wrote, "Our true nature is the nature of no birth and no death. Only when we touch our true nature can we transcend the fear of non-being, the fear of annihilation." There's a place in Greece, I'm a Greek American, and there's a place in Greece called Mount Athos where these ancient monasteries are. And in one of the monasteries, St. Paul Monastery, these are over 1,000 years old, there's an inscription over the door that says, "If you die before you die, then you won't die when you die." And I'm sure many people look at that and think, what are they referring to, whoever wrote that? But it seems that it's this experience of this death, of approaching death, as some people have in these very dramatic transpersonal experiences, and of coming through that with a renewed capacity to live fully in the moment, and to alter their perspective on their life. It's quite remarkable. It's interesting, in near-death experience phenomena, we see similar outcomes in terms of the values. Kenneth Ring and Raymond Moody, as many know, have developed this near-death experience research. People who have cardiac death on the operating table and come back through resuscitation and report these experiences. And he reports that, again, the common feature is this one of love. All these scientists now, we're talking about love, because when we ask patients what changed them, a lot of things have, a lot of insights into consciousness, but it's this gratitude and sense of forgiveness for themselves and others that's quite remarkable. And as I said earlier, it's not just a drug experience. These aren't really drug experiences per se. I think we're worried for these experiences. We know people have them in the ordinary states of consciousness. There's something called the overview effect. You can Google the overview effect. It's when astronauts, by looking at the as Carl Sagan called it, the pale blue dot, it triggers these peak experiences. Edgar Mitchell, on the way back from the moon in 1971, Apollo 14, had a very profound peak experience on in the spacecraft, and wrote about it. And you can Google that. It's remarkable stuff he wrote. But he says, I was looking out the window at the stars, the sun, the moon, and it triggered this experience, this incredible altered state, this insight. He called it an epiphany. And he had the insight that all the molecules of my partners of the spacecraft were manufactured in some ancient generation of stars. And he came back to Earth and left NASA and actually dedicated his life to working with understanding these incredible states humans are wired for naturally throughout history. And we believe that at the mystical core of the world religions, all these mystical experiences. But it does seem also that these medicines used in the right way can generate that experience. And now we see kind of positive clinical outcome. So in closing, we see for end-of-life distress and cancer distress, we see a really shift in how people could challenge assumptions on the body or what death is or insights into that. People have an enhanced sense of gratitude, of forgiveness towards themselves for all the shortcomings in their life or others. Connection to what they call a sacred experience, the transpersonal realm, improved psychosocial functioning, an increased capacity for time living, enhanced meaning making, and then overall, these medicines are now used in, as you know, people may have read about PTSD, depression, addiction, other therapeutic applications. We're learning more about the brain science, the neurobiology, what happens in the brain that triggers this change in the mind. And also, can it be used to understand consciousness? What is consciousness? We don't know. Is it generated by this remarkable brain we all have, or is it somehow more complicated than that? What is the source of consciousness? And it's really an exciting, I think, the final frontier of science as we explore that. In closing, this is a tribute to Albert Hofmann with the blue jacket in 1938, discovered LSD by accident. And the gentleman with the red vest, Gordon Wasson, who came across psilocybin mushrooms in the 1950s, and now both medicines are being used in clinical treatments for depression and end-of-life suffering, and both men supported the research and the sound use of these. And finally, last slide, just a quote from Albert Hofmann, who died over 104 years old, I believe, 103, and he wrote, "Alienation from nature and the loss of experience of being part of the living creation is the greatest tragedy of our materialistic era. Therefore, I attribute absolute highest importance to consciousness change. I regard psychedelics as catalyzers for this. They are tools which are guiding our perception toward deeper areas of our human existence so that we again become aware of our spiritual essence. Psychedelics in a safe setting can help our consciousness open up to the sensation of connection and being one with nature. It is my great concern to separate these medicines from the debates about drugs and to highlight the tremendous potential inherent in these drugs for self-awareness, for therapy, and for research." So with that, I will close, and I look forward to some questions. Thank you.
Thank you, Dr. Bossis. Okay, we have a few questions in the Q&A. We will start with, can you please speak to the concerns for interactions with psilocybin and medications, especially SSRIs?
Yes, good question, great question. So till now, we've people who are in these trials, and there aren't many, there's only a few trials where it's still in the infancy, but we've tapered them from the SSRIs if clinically safe and appropriate, and in consult with their psychiatrist, of course, because SSRIs and psilocybin both act along serotonergic pathways. There could be an effect in terms of additive or another way. So there's some conversation now, do we have to still do that? And as of now, we have, and on new trial, we're going to do that again. But there is, so people do come off their SSRIs. Clearly, if that's going to be not safe, or not indicated clinically, they wouldn't be in the trial, and the psychiatrist, we wouldn't do that. But for folks who could safely come off it, we have withdrawn those medicines.
Thank you. Next one. Thanks for this. It's remarkable that just one treatment session can have such profound effects. It seems like most of the work has been done with patients on active treatments. What are your thoughts on using this therapy for cancer survivors, post-treatments in remission, experiencing distress, anxiety, and/or depression, and struggling to adjust or cope with their cancer experience?
Wow. So a great comment and a great question. So the comment, yeah, that I may have not said this, but I hope it was implied. This is a paradigm shift in medicine. If we still continue with this research, most medicines people take, they take every day to achieve the desired effect. And at best, SSRIs and anxiolytics, and they're helpful. Obviously, they're tools. They quiet the symptom. They quiet down the distress. These medicines generate this experience one time. In some studies, there's 2 sessions. And it's the insight of the memory of the experience of the actual, working through, being with the suffering. It really calibrates how we look at suffering. It just, they move into the suffering, and they're recommended to move into the distress, and through that cultivate insight. And then we see the change, and that's a remarkable shift. Great question regarding survivors. So to this day, that hasn't been done, but certainly, there are trials with major depression, other depressive disorders. Certainly, when these medicines are rescheduled, if survivors are having distress, that would be a great indication for these medicines. As of now, it's been solely with people who have active treated cancer. Although there was a few nurses who were in remission, actually, the one woman I spoke about, and she's doing great. She was remission, stayed in remission, but had incredible fear of recurrence and did quite well. Had a recurrence years later, a different body part, but did well with that as well.
Great. So another question about your upcoming clinical trials that you're planning.
Sure. So there's a few things going on around the country with different sponsors. Our trial, myself and 3 colleagues on the West Coast, Charlie Grobe, Brett Anderson, and Alicia Danforth, generating a multi-site, single-dose psilocybin trial to be housed in palliative care settings, and not just with cancer, but with any diagnosis. And it'll be the first time that kind of large multi-site trial. We're currently working our way through the FDA, just applied to the FDA. We hope to be on site seeing patients by the end of the year or the turn of the year. There are other trials beginning to have protocols as well. So it's an exciting time. And again, with the paucity of tools to treat that, we look forward to doing this trial as well. We hope it's a brief trial because of the multi-site component that we finish in 2 years or so, and publish that 2 or 3 years. And then we hope in 5 years or so that this medicine is rescheduled by the FDA and the DEA for clinical application. So far, the results have been good, but we want to keep doing research to really assure efficacy and assure safety. I want to shout out again, these are in clinical trials. These experiences can create really dramatic shifts in consciousness and emotional fright. And without that model we work with, preparation, recommendations, assurance during the session, guidance, how to move into the experience, and therapeutic integration, all bets could be off when done on their own. So I want to highlight that.
Thank you. Let's see. Can you talk about how you see these medicines being used in a conventional medical setting in the future?
Yeah, well, I mean, we'll see what unfolds. There's so much going on in the field, as people may know who are reading about the field. It's very fluid. There's a lot happening with states trying to get rights to do this. We're on the FDA track, and how we'll look and how we're going to scale up. Thousands and thousands of therapists to do this. They're all unknown answers. So we'll see how it unfolds. The hope, of course, is that as they become rescheduled and legally available for different clinical indications, that we would see, of course, in primary, in palliative care settings, hospice settings, but that we would see it in all medical settings, that we could see it in small clinics and group practice. And, people who have the license to practice and are trained in this could do this in smaller settings. So it could really be covered across healthcare and city and a country and across economics, economic strata. It shouldn't be only available for those who can afford it. If indeed it costs money, we would hope that it's reimbursable and that it's available to all people in all different clinical venues. Whoops, I think Morgan froze. Can you hear me, Morgan?
Yes, sorry, just a little technical difficulties. I'm going to keep my camera
Okay.
down
Okay.
just to assist. But okay, thank you for that. The next one we got up is, are the doses that you're using considered microdosing? And if so, can those doses be used with SSRIs without concerns?
Okay, good question. And the answer is a flat no. So as I pointed out, these are high doses with the intention to generate this very dramatic shift in consciousness, where you wouldn't be able to walk around and function normally. If you're lying on a couch, there are people there to provide assurance as you go into this significantly changed, altered state. And that state's been linked with these better outcomes. Microdosing, this is not microdosing. Microdosing, people now read about that. Just to be clear, I'm going to stay in my scientific lane because people will say microdosing, they're getting great benefits, and we're reading in the media about that, and perhaps they are. I'm not but in terms of scientific research, there are no studies yet showing that microdosing is effective in treating depression, and it's not being used in this population yet. There's no, because again, the hope is to, in this very dramatic change in consciousness, that there are, in the spiritual state of consciousness and this different ontologic shift, that there are insights about self, death, consciousness, life, that are very profound and existential. Microdosing does not produce an altered state of consciousness. By definition, microdosing is a dose so small that it's subclinical and there's no perception of a change, but the theory is that it's still doing something when taken every third day or for months and months, that it does something in terms of mood and other things. But we don't work with microdosing, and the two studies so far have not shown it to be more fruitful than placebo, but we'll see. But no, this is not microdosing.
All right, next one. How do you feel about the timeline for the approval of these medicines? And what remaining questions do you feel need to be answered to launch a safe FDA approval?
Great question. So far, we've all the trials have received FDA approval, and the outcomes that you've seen have been positive. Concerns, well, timeline. So I think we're at 5-year marker. We're such an incredible time in our life here. Who knows? Everything's so fluid, but 3 to 5 years at best, but probably closer to 5. There'll need to be phase 3 studies, and all this is in the making. I'm not sure if she meant the person that mentioned concerns, but I'll give my concerns. So I think, yeah, I'm fine with the timeline. I think we need to really replicate safety and efficacy. It behooves us to do that. So far, there's been a relatively small number of patients, less than 100 in these 3 clinical trials. There's many more to be done in the future trials. There's a small body of literature from the 1960s, but we need to see it on a larger scale, and we need to see it replicated. So I think 3 to 5 years. The big question is, how do we scale this up once it is rescheduled? If it is the training of therapists, which is now going on, but it's a very unique state of awareness that needs a very unique state of training, and that's still being looked at. So we have a lot to do in the next 5 years, but so far with the results, we're very happy, very positive, and the patients have been so remarkable to hear their stories. I didn't even read all the stuff. I had a couple of vignettes to read. I read one for you, but they were all so touching and poignant. And we stay in touch with them, and we follow them up. And humans have a capacity for change through healing that seems to be almost inherent to the nature of who we are, and that's remarkable. Why would consciousness allow these almost self-healing mechanisms to occur when in these altered states? And there's a lot we don't know, but it's remarkable. And we know from psycho-oncology literature and spirituality, meaning making are important, and these experiences generate tremendous shifts in consciousness that, again, we're naturally wired for as humans, but they seem somewhat separate from our life. And in today's wildly challenging zeitgeist with so much suffering, we're looking forward. Another trials with PTSD, with depression, with eating disorders, with smoking cessation, with other indications are showing similar results so far. And that's also very heartening. But yeah, we have a few years to go.
Very exciting. We're just about 1 minute out, so we'll just do one more question very quickly from Linda Carlson, who is the SIO president. How do you train the therapists in your trials?
Great question. Was this Dr. Carlson?
Yes.
Oh, good. I just wrote that. Good. Hi. Pleasure to be here. So that again, that the way we train it is very carefully. So when we began, we had mentors who were really from the first wave, and others walked through a very training model that we developed now for other trainees. Each medical center has their own program. There are public programs now. There's a lot of them. So people need to be careful where they go and what they do. There are some great programs. I don't want to give names of the ones I teach at, but they're really wonderful ones. And the medical centers set up their own training models. And so as of now, there's no experience the therapist can have in terms of the psilocybin. So we're hoping down the road that an apprenticeship model could occur where there's not only didactic training, which we do a lot of, lectures, readings, understanding the effects of the medicine, the arc of the medicine, how it unfolds, how we support it, the phenomenology and the nature of these experiences. That's all important. But can there be a way down the road where a therapist in training, when these medicines are legally approved for training models, have an experience in a year-long apprenticeship model where they have the experience as well, like a patient would, and sit in on cases, live cases to learn how to be a guide or a facilitator for the sessions, as well as the abundance of literature that we assign to read and talk about. Our new trial, we're going to have part of that apprenticeship model. While we can't give psilocybin to the therapist yet, it isn't legally FDA allowed for that. We're going to have at each setting two guides, two facilitators. One is an experienced psilocybin facilitator, and the other person is a newcomer who's a palliative care clinician at that center. So in time, we're actually beginning to, plant a seed for palliative care clinicians who have done the work and have been therapists or facilitators for when it's rescheduled. So really exciting. But it's the big question: how do we scale up? How do we create large training with dignity and integrity? And these medicines generate a lot of sensationalism, and we want to be careful. The results so far are really remarkably interesting, but we want to treat this with the sobriety and the importance it deserves. So, yeah. And Linda, I look forward to speaking to you.
Thank you, Dr. Bosses. I think we'll wrap it up here. We have a few more questions in there, so maybe we can discuss farther for a part 2 to continue the discussion of the webinar.
We can do a part 2.
Yes. Just a reminder to all the attendees that we will be posting this on the SIO YouTube and social media of the recording. So tune in for some notifications from us. And thank you again, Dr. Bosses, for a fantastic presentation. We look forward to seeing you again here in the future.
Thank you, Morgan. Thank you, everyone. Be safe out there and look forward to seeing you all someday. Thank you.